Thank you. I just wanted to ask a couple of things that I know that my patients will sometimes say, and one of them is the importance of seeing the same GP in primary care, because quite often you'll go and see a different GP, they don't understand the history, I get asked the same questions all the time and no one understands. And I know that's a really challenging view forward, but when we roll forward with these multi-comorbid patients, is that a possibility in any way? But the other thing also is the patients who miss appointments, how often do we ask why they've missed them? Because quite often it's because they're unwell. If we knew that at the time, we probably would deal with them a lot faster.
So the question is trying to maintain continuity, and that's the forever challenge of trying to do that. We know, I think it's easier in perhaps slightly smaller practices with perhaps smaller patient list size to achieve that. When you start going up to scale and you're dealing with on-the-day demand, it's whoever you get on that day, and it can be difficult. And I think the way we can get better at that in primary care is to be proactive, and therefore we heard from Gavin that his GP kept in regular contact with them every 4 to 6 weeks. And I think for our complex patients like Gavin, we should maybe have an arrangement where we reach out on a regular basis, so we can be proactive, so we manage that patient better than them having to come in and ring on lucky to get an appointment on the day if they ring through.
I think. Can I just make a point about listening to Stuart and listening to the gentleman there as well? There is a big wide range of sort of sources, and where I work, the heart failure services are different to where you are. And I think one thing, talking to some of my colleagues, what I see is that there is some degree of disconnect with the grassroots, GP services to primary care. And I think going forward, so with the landscape changing, it's probably good to have more sort of, resources put in. So, for instance, I mean, there are a lot of GPs who are quite interested in doing a role of a sort of a special interest. My colleague again. But it's just taking the time to do it. There are a lot of people who, are unable to do it. So, but I think it's just getting some sort of a uniformity would be good going forward.
I think it's a good point, and just to emphasize, what we see in primary care, it's not too different from secondary care in some ways. So we see patients see different consultants in different clinics as well. So again, that continuity is not that well maintained either in secondary or tertiary care sometimes, where they come in via the emergency department as well. So I think trying to achieve that will be perfect, but it's some way away, isn't it, at the moment?
Yeah, I think we have to be realistic about it, don't we? I mean, many GPs do work part-time, and the problem with GPs who have become GPSIs in cardiology, like I think the three of us are, is that often we have other roles as well. So I work for the Innovation Agency, I used to work for the Community Heart Failure Clinic. So literally I cannot be in practice every day. So what I do for my patients is put very careful plans in place and help them understand what to do in each eventuality. So my notes read like flowcharts. If this happens, do this. So most of my patients don't have to see me on specific, it doesn't have to be me then, because they know what to do while they wait to see me. And that doesn't tend to create too many problems. I think some of that's about good communication, ensuring what you put in the notes is legible and understood, so in an emergency somebody else can follow it. But don't underestimate the part patients play in managing their condition to facilitate that really.
I think the other point is that we're using tech a bit better now, so we use e-consults, and so I will often ask a patient just to drop me an e-consult in a 4-week time for review. So if it was a blood pressure change or a change of medication, to let me know the outcome. And then I can, so one, they don't need to ring up, they don't need to try to get an appointment, they can communicate with me that way. I can then look at that when I have an admin session to do that, then reply, and that way we can keep, so we've got to find other ways to keep in contact with our patients, so it's using different methods of staying in touch.
Thanks. Any other questions from the audience?
Just a quick question for Stuart, really, about I was interested in PCHX, sort of review and audit I was just wondering I mean, we all want to find cases, and obviously case finding is very important, but how did you fund that? Who funded that?
So I was involved in this project. It sort of started in Manchester, actually, and just a bit of background. So we're all very aware of those patients that exist in the community that we don't know about. So patients with a historical diagnosis of heart failure that have been discharged once they've been maybe optimised 10 years ago and newer therapies available. Patients that might present to A&E, offloaded quickly and are discharged prematurely and are not seen by the heart failure service. They're discharged not on the right pills, and so they get readmitted. Patients that are just sit at home and are knackered and tired and don't see the GP and accept those are their symptoms because they're getting older. So this was a way of finding that population and allowing a consultant cardiologist with interest in heart failure to see them in their own GP practice, to optimise them, to consider them for device therapy if necessary, and to bring them into the heart failure service as well if necessary. In terms of funding, it's completely free. So this exists now in Liverpool. So we've run this throughout the country. We've had the paper. It's been accepted in the European Heart Journal. As I said, it started in Manchester, sort of spread nationally. We'd like to expand it regionally in Liverpool and use it as a sort of almost a new model of finding these types of patients. It's completely free. There's a company we work with called Inspira Health. Carol is up there. If you give a wave, Carol, if anyone wants to ask about it. And they go in and they audit the practice and look to find patients that might have either a previous diagnosis of heart failure or may actually be undiagnosed. They then will sort of pull out all those patients. They're then reviewed by a consultant cardiologist, and then we will go out to the GP practice. And we first will see the patient and make sure they're optimised, but also the legacy it leaves behind is one of education. So often when we see the patients, we have a GP or a practice nurse or a pharmacist sat in with us, and we can chat and sort of talk about what's going on in heart failure, how can we help you, allows us to engage, and then it could be the patient's optimised at that point, it could be the patient's fine, we do nothing, it could be the patient needs referral into the local heart failure device service, and Stuart gave a great case study where the patient ended up with a CRT device. And I think when we sort of nationally, when we've looked at the figures, I think 50% of the patients we looked at needed medical optimization, which is really important. Just increasing an ACE inhibitor, adding an SGLT2. 15% needed a device putting in, which implies that there's huge amounts of patients out there with an ejection fraction less than 35% that we're not doing anything about. So it's a great project to be a part of. We'd like to expand it, and at the moment the message is if you're interested, then please let us know. You can come and talk to me, Carol and Tony at the back there as well.
I think the other point I'd like to add to that is it's what happens after the first 12 months. So all this work gets done and they get optimised, and after 12 months they're back in primary care. And what I'm really keen to develop at a network level is how do we then follow these patients up year on year, not just after get everything done in year one. Otherwise they can fall off the radar again, things can get stopped, missed, and not restarted. So it's how do we create a robust heart failure service follow-up in primary care, and I think that's going to happen through networks and working with our heart failure specialist colleagues in hospital and developing our community cardiac nurses to work together so we can keep these patients under regular review so they don't decompensate.
I mean, brilliant project, and of course it's great to find these cases, but I suppose what I was getting at, who funds Inspira Health?
So the money comes overall from industry, from Medtronic, one of the device companies. Right. Now, if we found a patient that needed a device, they would not automatically necessarily get a Medtronic device. That's been made perfectly clear. They would get the device that, as clinicians, we feel is best for them.
Okay, thanks. I think we'll just, if you've not got any more questions, we'll go to some of the online questions. There's a few of them. I think one of them, again, it's an extension of the primary care heart failure service, asks about HFpEF. So just to clarify, it's a great service, the PCHF service. Of the patients who get readmitted, a significant proportion are those patients who were historically diagnosed with HFrEF or LVST, not on the right treatment. So 5 years back, we didn't have as much Entresto, we didn't have SGLT2 inhibitors. So these patients certainly deserve a relook to prevent those adverse outcomes. It might be hospitalizations, it might be mortalities. But it is largely those who have a pre-existing diagnosis of left ventricular systolic dysfunction or HFrEF. It does not include HFpEF. and it does not replace the nice diagnostic heart failure pathway, where we still do an NT-proBNP and refer to the heart failure services. So just to clarify that. I think there was one question, I don't know if I can give it to one of you, about when do we scale back on the diuretic? Any thoughts about that?
So I think it depends, and you need to tailor it to the patient, really. I mean, I think the classic is when obviously you've had somebody who's fluid overloaded and you've commenced all their standard heart failure therapy and their condition has improved significantly with no evidence of fluid overload now. I think at that point you can start to try and titrate it off carefully. I think it's important that patients understand when to restart. So I think it depends on the patient, it depends on what's happened to them. Obviously, if you've got a patient who has tried previously to stop diuretics and developed fluid overload again, that's a bit of a non-starter. But certainly if a patient's got normal renal function, escalating urea and no evidence of fluid overload, that's probably a good indication to try and scale back.
And again, some of the medications which are prognostic, like MRAs, SGLT2 inhibitors, they have a diuretic action. So you can initiate those and then scale back on their loop diuretic if they're euvolemic especially. So there's a question about device optimization in the community as we want to provide greater care away from secondary care and care closer to patients.
Most device patients will actually have some remote monitoring. And so it's often just a phone call to the local pacemaker clinic, and you can have a device interrogation done and get a report back. I think for most primary care colleagues, if they're concerned about a patient, they should be picking up the phone and speaking to somebody in cardiology services anyway. But you can get a remote interrogation done.
That covers most of the questions. If no one has any other questions, we can probably take a quick coffee break if that's okay. Thank you again to Gavin for patiently waiting for us. So thanks.